Good evening, all. So that was not Teachers of Tomorrow. That was about next annual AIOCM meeting. So we'll be shortly starting our TOT session here. So I'll announce the hours that we have planned for you. So the winner team will take a trophy, okay, and 3 gold medals, 1 for the mentor, 2 for the mentees, and there will be 2 runner-up, first runner-up and second runner-up. They will also get silver medals for that. And by judges, and we have Dr. Nisat Hussain. She is an additional professor of microbiology at AIMS New Delhi. She will be one of our judges. And Dr. Ilan Kumar sir, he will be our second judge. And Dr. Madhu Daraju sir is here. He is going to be our third judge. So who is going to present first? That as Gopal sir will tell you that.
Yeah, so good evening to all, and may the best team win. That's what we always say. And these are the teachers of tomorrow who will actually further the torch of our ophthalmology teaching over the years to come. And these are all young budding ophthalmologists, probably just in their post-graduation or immediately after the post-graduations, who will be coming here and teaching us a topic 4 minutes. Okay, in 4 minutes, you will light up our jnana in such a way that, that particular 4 minutes is going to be a path breaking to our life as well. Because a lot of these topics, like me being a retinal surgeon, doesn't know anything about cornea. And if you are able to teach me, grill into my head, what is the approach to a corneal ulcer, I would be really happy. So the judging is not, has Dr. Madhu come? Yeah. So then we will not have a person. If a person is to be a judge, I think he should be from the beginning to the end. So we will have 2 people here, Dr. Ilan as well as Dr. Nishad, and we will not be just looking at the topic and the content, but how you are delivering the content so that an ordinary or less than ordinary student will be interested in hearing your lecture and gain something about it. All right? So you can use various techniques, including asking a question, getting them out of the class, making them stand up on the bench. Whatever you want to do, you can do to capture the imagination and attention of all these people. So we are having lots. So we have 5 teams here. Tamil Nadu, who is the mentor of Tamil Nadu team? Yeah, great. So Tamil Nadu, can you take the lots? I mean, have we made the lots? Upinder? Yeah. Tamil Nadu, can you just tell who are your mentees and tell a few? We have the presentation on, right? Can we have that presentation? Yeah. Yeah, teachers of tomorrow. Next slide. Yeah, team Tamil Nadu. Yeah, Dr. Shreyas. Yes, you can talk about your mentees and take the lot.
So my mentees are Dr. Kavya Priya. Currently, she is senior resident at JIPMER Pondicherry, and Dr. Anurit Kaur. She is junior resident in JIPMER Pondicherry.
So we'll have their CVs as well, and you can take the lots. Bhupinder, is it ready? Yeah. Okay. So this is to find out which is your sequence.
No, it's not sequence. These are teams. Team's name is here.
Okay.
So which is the first team going to present?
Yeah.
So you have to choose somebody from them who will take out the chat, not the participants.
All right, you can have anybody. All right.
Maybe.
Who is not participating?
Take out any chat. You are
Yeah.
participating.
Anybody who is not
Ma'am,
participating
take out
here?
any chat.
Yeah, great.
Ma'am, take out any chat.
This is
The first team to present is Andhra Pradesh.
Andhra Pradesh. Can we go further to the
All are participating? Please take out any chat. The second team is Odisha. The third will be from Maharashtra. You are participating? And you all are participating? Then we'll go to our judge.
Yeah.
Just open it, sir. So it's Team Delhi.
And
So,
so
we are
the
left with
fifth.
last, so I'll take the privilege to announce this name. So last is Tamil Nadu. I
All
hope
right.
you remember
So the first
sequence.
becomes last and the last becomes first, is it? Okay. So let's have the intro on, please. Dr. Shreyas has mentored two of them. Can we have to the next slide? Anurit Kaur. She will be talking to us about approach in a case of ocular mechanical trauma, right? Yeah. Next slide. And Dr. Kavya Priya N. Recent advances in amblyopia. All right. Next slide. So we have Team Andhra Pradesh. We have next slide. So mentored by Dr. P.A.S. Chalapati Reddy sir. Next slide. All right. So his mentees are G.V. Anurag. Can we have G.V. Anurag, and he will be presenting approach to a case of diplopia. And next slide. Akanksha. Yeah, you will be presenting. Can we go to the previous slide, please? Previous slide. Surgical options in primary angle closure glaucoma. All right. Then go to team. Next slide. Team Odisha. Yes. We have Dr. Shweta. And your mentees are, next slide, Dr. Rohit, approach to a case of proptosis. And Dr. Tanya, anti-VEGF in CRVO. All right. Next slide. Maharashtra, mentored by Dr. Anagha. Next slide. And mentees are Neelambika Kulkarni, approach to a case of ptosis, and Monish Naik, who is presenting management of diabetic macular edema. Oh, it's other way around. All right. Okay. Next slide. Team Delhi by Balla sir and Jatinder Singh Balla, and the mentees are Dr. Abhijit. Yeah. Dr. Abhijit is senior resident at RP Center, recent advance in retinoblastoma. And next is Dr. Lavanya, approach to a case of corneal ulcer. All right. So these are the 5 teams. So the first team to present is Andhra Pradesh. We will have 4 minutes to present, and at the end, the judges can ask a few questions, and we will also ask the audience, because audience are all students. All right. So you can ask the audience some questions based on that. Audience can ask some doubts if you want. Let us start with the first case.
So I would request the judges to come here, please.
Yeah.
Come to the dais.
Who is going to be the timekeeper, Bhupinder? 4 minutes? All right. And it is not just the subject. Madhu, sir. Yeah. All right. So we have 3 judges in all. That's great. And so we have, you can just discuss about the marks, how the marks is being given.
So they will be scoring out of 10, 3 judges, and there will be one audience poll. So we'll ask from audience how they, if they really understood what the teacher taught them. Depending on the response, we'll give them some marks, but that will consider only if there is a tie. If there is a no tie, only the judges score will be counted. Fine. So after each presentation, there will be 2 minutes for asking tough questions. So I would encourage the other teams, please ask tough questions, so that that will help you in scoring over the other team. Okay. So maybe can we start with our first presenter?
Yeah. Yeah. Come here. Who is going to time him? 4 minutes. Is there a mark for exceeding time?
Yes, there is negative marks. So please don't overshoot the time.
All right.
So I'll be dealing with the case, approach to a case of diplopia. When does the time start? Just let me know when the time starts.
PPT, this is your PPT, right?
Yeah,
Okay.
this is the PPT.
Yeah, you can start.
Please
now.
start.
You can start.
All right.
Time.
Good evening to one and all. I'll be dealing with how to deal with how to approach a case of diplopia today. My name is Dr. Anurag. Coming to the definition, diplos and opos are Greek words meaning double in vision. So when an image of an object falls on a non-corresponding part in 2 retinae, a sensory phenomenon occurs that is interpreted as diplopia, that is perception of an object in 2 different spatial locations simultaneously by the patient. Diplopia can be of the following types. These are pictorial representation. Now, binocular diplopia is almost always due to misalignment of eyes. Misalignment of the eyes may occur secondary or to neurological or mechanical factors, and this will disappear. This type of diplopia will disappear when one eye is closed. So this is a complex picture with a simpler picture next to it, establishing the Panam's area. Now, when images fall beyond the Panam's area is when we perceive it as diplopia. So monocular diplopia occurs due to diffractive phenomenon where a single image is getting duplicated, and this is almost always because of local ocular phenomena. Pinhole will eliminate this, whereas closing one eye may not eliminate this. So on the right we see what the patient perceives, and on the left we see what the patient feels. This is a picture showing duplication of the optic disc as seen on the fundus photo, and it's occurring due to a subluxated IOL, and the other side picture shows a natural subluxation of the lens. Now, when approaching a case of diplopia, 4-step test in your mind. Is it monocular or binocular? If binocular, are there any abnormal patterns of eye movement? If there are abnormal patterns, what could be the anatomical structure? And what could be the possible etiology involving that structure? This will help us direct the investigative workup and reach a correct diagnosis. So this is just a list to show you how many symptoms can present with diplopia. So it's not like 4 or 5 things. It's a big list. So as far as history goes, 6 questions in your mind, which will be dealt in detail. The first being, how are the images separated? Horizontal separation is medial or lateral recti. Now we know lateral recti are for divergence and medial for convergence. So lateral recti involvement is worse at a distance, medial worse in near. Vertical diplopia is due to cyclovertical involvement. This can either be superior or inferior recti and or the oblique muscles. Now these can either be involved alone or in combination. So this is a simplified 3-step test for diplopia and up gaze and diplopia and down gaze. Now, when we speak about worsening of symptoms, 2 key factors. When we're thinking of a paralyzed muscle, the field of action of the muscle is where the diplopia is worse. But when you're talking about a restricted muscle, it is the opposite to the field of action of the muscle. Now, clinical course and symptoms, onset, offset, variability, and progression are key for any symptom that presents. These help us identify the etiology here. Now, onset, sudden onset is usually an ischemic cause. Fluctuation of symptoms rarely can be a transient ischemic attack, but more so variability and fluctuation are relevant for neuromuscular disease and motor end plate dysfunction like myasthenia. Recurrence can be seen in rare cases like Tolosa-Hunt syndrome, vasospastic migraines, where the same cranial nerve may be involved multiple times and resolve spontaneously. So eye pain, localized pain in and behind the eye and the orbit suggests an intraorbital pathology. Sudden onset, severe headache, in quotes, worst headache of my life, definitely refer him urgently to a higher center because it's likely an SAH causing the diplopia. Now, pupil involving third nerve palsy can occur due to an SAH. That's why most third nerve palsies should be treated as medical emergencies. Now, pain in the V1, V2 can be involvement anywhere from the cavernous sinus onwards. So, pain in the V1, V2 distributions should also be a key part in the history. Other ocular associations can be ptosis, blurred vision, headaches, and fatigue, weakness, and difficulty in swallowing. Further symptoms, oscillopsia in gaze palsies, lid retraction and proptosis in thyroid eye disease, temporal headache, jaw claudication in arthritis and GCA, and abnormal head postures in case there were any squints. Now, family album history. Past history of any strabismus or amblyopic eyes is very important in cases of diplopia. Usually, though, if the patient is presenting with diplopia, this is not a childhood thing. This is something recent onset. This is something acquired. Now, past photographs of the patient might help in looking through abnormal head postures or at least pinpointing when the squint started. Associated CNS symptoms, strokes involving the midbrain and or brainstem can have 3rd, 4th, 6th nerve involvements, the MLF involvement, vestibulo-ocular nerve pathway.
I think you have to stop here. You have already crossed the 4 minutes time. Conclude. Come to your conclusion slide.
Okay. It's close. I don't.
It's already 4 minutes 30 seconds. I am running a stopwatch here, so I am sure.
So I'll just go to my last slide.
Yes.
In short, remember a 6-5-4 rule. 6 questions during history, 5 points in examination, and 4 questions as a mental exercise. This 6-5-4 should help you get to a 3-2-1 for your diagnosis of the diplopia. Thank you. I'm sorry for exceeding the time.
Okay.
That was
Any
nice.
questions?
Any question from the judges first? Because you are also students, sir.
These are my references.
So yeah, I think he couldn't finish his presentation. So No, no, whatever slides he showed, that were quite good.
Yeah, I slept very well. Thank you. Okay, yeah, yes, I slept very well. Okay, thank you. No, you said 654, right? 6 questions, 5.
6 questions during clinical history, 5 pointers during ocular examination, and 4 questions running in your head. Like the 4 questions are basically, is it monocular or binocular? If it's binocular, is it eye movements? If eye movements, which structure involved, and what could possibly involve that structure? So this 654 is like my thought process that if you fix the 654, you shouldn't miss a diagnosis of diplopia. Considering these, we know a huge symptom complex exists, a huge variety exists where anything can present with diplopia, monocular or binocular. So we should be very thorough when we are examining this, and we should know whether it's monocular or binocular, and if whichever kind, treat it correctly.
The presentation, actually the content of the presentation was very good. So we are here to see the teaching skills of the person. So the content will be good. We have to see how much impression they are able to create in the minds of the audience with the 4 minutes provided. I'm sure you have taken topics of which the content you are thorough with.
Approaching a case of diplopia was a little hard, man, for 4 minutes.
We will, that is what. We have not given you this task to make you comfortable.
Exactly.
Being a teacher is a very difficult task. So that is what we are here to judge you for. Definitely you were very confident and the content was good. But I am making a general statement here that we are judging your teaching skills as well. So that is what is also important, to engage the audience, and content becomes very small. If we are not able to engage with the audience, then the content does not have any meaning. Praful will correct me.
So for all future teachers, if you finish your class before the scheduled time, the students will appreciate you and they will love you. So remember that. Can we have next?
So one thing is, Winston Churchill, he was the British Prime Minister when India got independence. I don't honor him a lot, but he said, if you want me to present something in 60 minutes, I can do now. If you want me to compress that into 5 minutes, tell me 1 month before. That's the amount of effort that one has to put in to make that content smaller. Diplopia is a long topic, but you have to make that smaller. All right, can we have the next presenter? You wanted to ask about audience?
Audience, but I think we have only participants here.
Yeah, that's fine. Then let's have the second.
We are not
presenter.
taking audience poorly.
What is your topic?
Use the mic. You are a teacher. You are not a student. Don't be scared.
Surgical options in primary angle closure glaucoma.
10. Each one of you can put in 10. All right. So her time starts now.
So
No, what? Excuse me.
it's not
Let the slide come.
Name. Akanksha. Andhra Pradesh. Akanksha from Andhra Pradesh. Andhra Pradesh. Okay, so the next person can come here and tell the topic and so whoever is next. Which is the next team coming? Yeah, good. So you be here to manage your, yeah.
She has already submitted it, I think, right? AV team? Please start a PPT.
It is not seen there or what? All right. So please make sure that you have a lot of area to cover. You can walk.
You all are teachers, okay?
Yeah,
You are not students here.
yeah.
Remember that.
Yeah. Don't limit yourself to the mic.
Rest of the team, please upload your PPTs, okay? We won't allow you extra time for that.
Just make sure that your PPTs are here. Just make sure, come here and see if all the other PPTs are here. There are 10 PPTs. Are they here? Please check.
Please start. Yeah.
Start. Good afternoon, everyone. Today my topic of presentation is surgical options in primary angle closure glaucoma. So pupillary block, as we know, is the most important mechanism in primary angle closure glaucoma. In acute attack, laser peripheral iridotomy is the procedure of choice. But what if it is not possible? Peripheral iridoplasty can be done further. In chronic cases, the management is scenario-wise, which we'll learn further. So incisional iridectomy has been replaced by laser iridotomy now. However, studies show filtration surgeries are more likely to be required after laser iridotomy than incisional. Filtration surgeries include trabeculectomy, where a fistula is created between anterior chamber and subconjunctival space, and a partial thickness scleral flap is used. It is a gold standard in surgery in glaucoma. So let's see different scenarios. Now, if there is a case of PACG without any significant cataract, but the IOP is uncontrolled medically, conventionally trabeculectomy is preferred. But the recent EAGLE studies suggest that clear lens extraction has been superior to laser peripheral iridotomy in mild cases of glaucoma. So what is the optimal timing for lens extraction? There is no clear consensus yet, but studies suggest within 1 week of medically controlled acute attack or at least after 1 month can be done. So PACG, next scenario is when PACG is there without significant cataract and the IOP is controlled. Now usually trabeculectomy is not indicated in such cases, but if the patient is getting intolerable to AGMs or patient is not affordable or if patient is not compliant, trabeculectomy can be indicated. As well as this, lens extraction can be indicated in cases without pupillary block like in plateau-iris syndrome, nanophthalmos or anterior lens vault. Now let's see scenarios where PACG is associated with significant cataract. So if there is a case of mild to moderate PACG with cataract with medically controlled IOP, in such cases, let's see how many anti-glaucoma medications patient is using. If the patient is using only single drug therapy, phacoemulsification can alone be sufficient in such cases. While if patient is using more AGMs, phacotrabeculectomy has been proven more beneficial by the RCTs. So if the cases of advanced PACG with cataract with medically controlled IOP, the treatment should be done in two-stage approach. Phacoemulsification should be preferred initially and later trabeculectomy can be considered. While if there is advanced PACG with medically uncontrolled IOP, trabeculectomy alone should be done initially to control the IOP and later phaco can be done. Why is this then and why both surgeries are not done together? To prevent the washout phenomenon. Now next is the glaucoma drainage devices. Now if the patient is having refractory glaucoma and patient is not responding to medical therapy, glaucoma drainage devices can be done. As well as in failed trabeculectomy, glaucoma drainage devices can be indicated. Here I am showing the photo of a patient where Ahmed implant was put. Aurola vacuous drainage implant has also shown successful results. The next is goniosynovial lysis, where we do mechanical lysis of peripheral anterior synechiae. It is indicated and beneficial only when it is done in shorter duration of angle closure, that is within 1 year. And studies have also shown that phaco with goniosynovial lysis had no significant added IOP lowering as compared to phaco alone. The next is endoscopic cyclophotocoagulation, where the advantage is that we can directly see the ciliary processes, but it is in research still, and RCTs show that phaco with ECP showed significant additional IOP lowering than phaco alone. The next are microinvasive glaucoma surgeries, which are conventionally used for primary open angle glaucomas, but can be used in PACGs also, which include phaco with goniosynovial lysis, with goniotomy, trabectome, and eye stent, where IOP lowering has been significant. So to conclude, PI is the procedure of choice in all PACG cases. Trabectomy remains the gold standard for all glaucoma cases. Phacoemulsification alone can be sufficient in mild PACG. Phaco with trab is the best for moderate PACG. For advanced glaucoma, stage treatment approach is the best. And glaucoma drainage devices are effective in advanced glaucomas. There is a scope for technique like clear lens extraction in PACG with high lens vault. MIGS can be effective in PACG, but more studies need to be required to generalize an approach. Thank you.
Judges, please. You can ask your doubts and clear them.
In your conclusion, your third point,
Yes, sir.
phacoemulsification for mild glaucomas. That's what you said.
Yes, sir.
Do you mean clear lens extraction or if it is with cataract?
With cataracts.
Any idea why, what is the role of clear lens extraction in angle closure glaucomas? Has any study been done?
Yes, eagle study has been done.
Could you tell what it is?
So when the lens is located anteriorly and there is anterior lens vault, it can cause a significant anterior angle closure. That's why removing the lens can cause deepening of the angle closure and therefore relief of symptoms and IOP.
Is it only short term or long term? What is the long term comparison?
Sir, in mild cases, it has been beneficial when the patient was followed up at 6 months and 18 months. But eagle study actually is not.
In the long run, there is no difference between removing the lens and doing only a peripheral iridectomy. That's right.
Looks that this student is very smart, huh? Okay, yeah.
Basic doubt. Why is trabeculectomy the gold standard? Why do you consider a gold standard still?
Ma'am, because other surgeries like phacoemulsification alone or glaucoma drainage devices, these are indicated and has been into recent trials where trabeculectomy has shown sustained results, constant results after operation. Like IOP has been well maintained.
All right.
Any question from the audience?
That is an actual doubt of a student. Very good, yeah.
Thank you.
Yeah,
So, is there any role of doing a PI, YAG peripheral iridotomy in cases of PACS? Any trial supports it? Or is there any data which supports doing PI in PACS suspect cases? Angle closure suspect.
No, it's a major
Major
trial and he's correct. But the issue with Indian population is you lose these people to follow. That's one reason why we still do YAG PI and PACS despite that study. That is the reason. It is quite a large trial.
now we have the next team, Team Odisha.
Hello, am I audible?
Yeah,
थोड़ा आवाज ऊपर करके
Team Odisha.
Hello.
And the first talk is on approach to a case of proptosis.
Hello, am I audible to everyone?
Yeah, go on.
Good evening, students. Just 1 minute. Can I start?
Please start.
Okay, you can start.
Good evening, students. What do you see in these two images? There is protrusion of one eyeball in this image, while there is protrusion of both the eyeballs in this image. Although interchangeably used, proptosis refers to prominence of eyeball secondary to an orbital space occupying lesion, while exophthalmos is secondary to dysthyroid orbitopathy. Today we are going to learn how to approach a case of proptosis. As with any other case, history taking is of paramount importance in a case of proptosis, especially if you want to get to a differential diagnosis. Let's say a baby presents to you with proptosis at birth. It could be a cystic eyeball. If a child presents to you with at 1 year of age, it could be a capillary hemangioma. If you see a proptosis which is acute, painful, it is rapidly progressing, it can suggest that it might be an infection, might be orbital cellulitis. If the proptosis is gradually progressing, the likely etiology is benign in nature, while if you see a history of proptosis, which if the patient is saying is long-standing, non-progressive, it might be an ocular dermoid. So, what else is important when it comes to a history? Is the proptosis positional in nature? It could be an orbital varus. Is there any change in crine? It could be an meningioma. Always ask for a history of trauma when there is a case of proptosis. Is there an increase with an upper respiratory tract infections? It straight away points to a diagnosis of lymphangioma. Ask for a history of any past chemotherapy. Any history of chemotherapy suggests that the proptosis might be due to an orbital meds. Any history of nasal pathology indicates that the primary might be in the paranasal sinuses. So, with this, we should never undermine the importance of a systemic history. Why is diabetes mellitus importance in proptosis? Mucormycosis, thyroid eye disease, neurofibromatosis, optic nerve glioma. So, along with the history, symptoms can give us a clue of what's lying behind. For example, a patient is complaining of diplopia. We know that the lesion is either affecting the muscle or the nerve supplying the muscle. If the patient is complaining of diminution of vision, we know that the lesion is either involving the optic nerve or it is compressing it. So, next up is the examination, which is done under all these headings. First is inspection. So, inspect what? The eyelids and the periocular area. So, what do you see in these images? There is eyelid retraction and there is lid lag. These are some of the signs of thyroid eye disease. What do you see in this image? This is a red colored lesion which is likely suggestive of an hemangioma, orbital component of which can cause proptosis. This image is showing eyelid edema and this is lid fullness. What else can we inspect? The globe position. Axial proptosis indicates that the lesion is intraconal, while abaxial proptosis indicates that the lesion is extraconal. In this case, it might be a frontoethmoidal mucocele which is pushing the eyeball inferolaterally. Next is palpation. Palpate what? The orbital rim. Any irregularities in the orbital rim can suggest a malignancy. Resistance to retroposition can indicate a solid intraconal tumor. Never forget to palpate the lymph nodes. If a patient comes to you with a pulsatile proptosis and Bruyon auscultation, straight away it can be a case of keratoconus fistula. Grossly, an assessment of proptosis can be done in two ways. One, we can use a worm's eye view from the from the below, and one we can use as Navziger's view from the above. So, absolute assessment of proptosis, of an axial proptosis especially, is done by either Hertels or Lures, and in case of abaxial proptosis, it has to be done with a two-scale method. Imaging and management is something we can take up next time. Thank you.
Good. Let's have the judges. These students have been listening carefully.
No doubt, it's very good class.
I was told I should not ask questions, I should ask as a student. Sorry to the two previous speakers. Okay. Good presentation.
Thank you, sir.
2-3 things what we liked. Okay, more than going into the topic, it was crystal clear. You did not hide behind the podium. You came out in the front, lot of expressions. One negative pointer you are showing with the other hand, but you had a pointer in the
Sir, the laser doesn't work on LED screen. That's why I had to show with my hand. Sorry, sir.
I have one question. You told about positional proptosis. I did not understand that.
Ma'am, orbital varus is something which can be elicited by a change in position. For example, I recently saw a patient, he was telling me that he is experiencing fullness when he bends down for some work. So I asked him to elicit Valsalva manure, and there was increase. That orbital varus was a probable angle. It was not causing proptosis in that patient, but if the varus was, for example, orbital, then it definitely would have caused positional proptosis.
That's good. So next we have Tanya coming in for anti-VEGF in central retinal vein occlusions. And one more announcement. Here we have only got one presentation they have not got. Please see who is the next person to be presenting. Please come here and see whether your presentation is loaded already. All right, over to Tanya. Can we start the timer as soon as the person presents? Yeah, start.
Good evening, students. Today we'll read about anti-VEGF in CRVO. So students, there are two new terms for you here. One is CRVO and one is anti-VEGF. CRVO is of two types, ischemic and non-ischemic. In the ischemic CRVO, a lot of features are present. But I want you to never forget these three features. Visual acuity is less than 6/60, RAPD is present, and extensive retinal hemorrhage is present. In the non-ischemic CRVO, vision is poor than normal but better than the ischemic CRVO. So a case of 60-year-old male comes to you with complaint of sudden painless blurring of vision in the left eye for 7 days, and patient is a known hypertensive not compliant on the treatment. On examination, vision in the right eye is 6/6 and vision in the left eye is 5/60. Pupil is reacting in right eye and the left eye shows RAPD. On fundoscopic examination, left eye shows extensive retinal hemorrhages giving a blood and thunder appearance and presence of macular edema. An OCT macula was advised for this patient. Look at the macula of the right eye. It shows a beautiful foveal contour with a central macular thickness of 217 micron. Left eye on the other hand shows presence of cystoid macular edema and the CMT is 482 micron. So this is a case of ischemic CRVO with macular edema. Why do we have to treat these cases? Because macular edema and ischemic retina, if not treated, will lead to distortion of the normal retinal architecture in a long run, leading to permanent vision loss in these patients. Who all patients do we have to treat? Patients of ischemic and non-ischemic CRVO with macular edema. So the question comes, how do we treat this macular edema? The first line therapy is anti-VEGF, which is given intravitreally. We can also give intravitreal corticosteroids, but this is not the topic of concern today. Before reading about anti-VEGF, we have to first know what is VEGF. The ischemic retina produces vascular endothelial growth factor, which increases the vascular permeability, leading to the collection of fluid, and in a long run, it will lead to production of new blood vessels that will be friable, will leak blood everywhere. This VEGF is very notorious and it is the culprit behind all the complications of the CRVO. So the anti-VEGF will block the actions of the VEGF. These three agents are used in CRVO treatment. Ranibizumab is FDA approved drug. It is given in a dose of 0.5 milligram in 0.05 ml given every 4 weeks. Aflibercept is also FDA approved. It is given in a dose of 2 milligram in 0.05 ml every 8 weeks. Bevacizumab is not FDA approved. It is used off-label, but it is cost effective. It is given in a dose of 1.25 milligram in 0.05 ml. The treatment regimen consists of loading dose given monthly for 3 to 6 months, and the rest of the regimen depends upon the condition of the patient decided by the treating ophthalmologist. So the case we discussed about earlier was given 1 dose of intravitreal ranibizumab, and within a month, the entire macular edema has subsided. It is completely resolved, and the central macular thickness has come down to 228 micron. And the patient went home happily with 6/6 vision. Take home message here is ranibizumab and aflibercept is FDA approved. Bevacizumab is cost effective, and in India, being a very developing country, to reduce the financial burden of the patient, we are still using bevacizumab rampantly. Thank you.
Great. Over to the students.
You were talking something about vascularity and giving anti-VEGFs. I didn't understand. When you were talking about macular edema, that's I think third slide, I think. One eye no macular edema, other eye macular edema, and then you said before giving we have to decide something about vascularity.
Vascularity we can see by doing fundus fluorescence. If the macula is ischemic, there will be no benefit of giving anti-VEGF because the blood supply is already gone and the tissue is dead. Anti-VEGF is useful if the tissue is hypoxic, not when it is anoxic.
So basically we have to do an angiography.
Angiography we have to do for the patients.
I don't have an angiography. Clinically, how do I make it out?
By all these signs that I've already told, you were not paying attention in the class. I've already told what are the features of ischemic CRVO.
Okay, maybe I didn't see the slide. That's what I was asking.
All right. I have one question. You told in India we are using bevacizumab off-label.
Yes, ma'am.
I want to know what is off-label.
Off-label, that it is not FDA approved. It is not approved, but still because we have done studies and it showed effectiveness in the patients of CRVO. So we are using it, but it is not recommended to be used.
But is it FDA? Ma'am, is it FDA? FDA to USA mein.
FD approval is not.
In India, do we need FDA approval?
For cough, I am taking ampicillin. Is it FDA approved?
That I don't know.
Okay. Okay. Teacher, you told us there are two new terms, CRVO and anti-VEGF.
Anti-VEGF.
What is CRVO, madam?
It is central retinal vein occlusion.
But you did not tell anything about that. You jumped into ischemic and non-ischemic.
Yeah, I know.
Okay, okay.
Because
okay.
of the time crunch.
Let's go to the next team. Good show. Team Maharashtra. Anagha madam is coming there and making sure everything is okay. Okay, Neelambika Kulkarni will be presenting on management of diabetic macular edema. One second. Odisha. The team that's finished is Odisha. All right, you can change it. That's fine. You can just change the name of the team. That's it. Okay, yeah. Can we start the time when she starts? You want the? It's not audible.
Am I audible?
Yeah.
Hello?
Now it's audible.
Yeah, okay. Can I start?
You can start.
So I hope I have everyone's attention by this cartoonic image. So this is a patient that has come to you today and he's saying that he has some distorted vision. So we look at his fundus and we see this kind of an image. We can see hard exudates which are present at the macula. Would anyone like to take a guess as to what this patient has? So a diabetic patient with metamorphopsia. This patient has diabetic macular edema. So today we are going to focus mainly on the management of diabetic macular edema, since in the last class we have discussed the pathophysiology and I hope you have understood that too. So what are we going to do in this patient first? We are going to do blood sugar levels. We are going to see fasting, postprandial, we are going to see the HbA1c of this patient. We will also look at the hypertension, we look at the lipid profile, the thyroid diseases, and we just rule out everything systemic. After that, we want to look at where exactly the edema is present. So we would like to do an OCT, right? On an OCT, we can differentiate whether it is a center involving or a non-center involving edema, or if it is a tractional or a non-tractional type, because this differentiation is very important when we start to treat this patient. So what can we see? We can have a cystoid macular edema, we can have a serous macular detachment, or we can have a tractional kind of a picture. The important OCT biomarkers include the central subfield thickness, which is basically thickness in the 1 millimeter center zone. So this is highly predictive and it's a very important marker to see how the disease is progressing. The other OCT biomarker is the disorganization of the inner retinal layer. So this is basically the inner retinal layers have lost their proper distinction. If it is seen in a patient with macular edema, it indicates that the patient has a poor visual prognosis. Also hyperreflective dots may be seen in this patient which represent the tissue disintegrity. On OCTA, we can see as the disease progresses, we have an enlargement of the foveal avascular zone indicating an ischemic pathology. And FFA is usually indicated to pinpoint these small areas of edema which might be later we want to treat with laser. So coming to the therapies, so the first line that we would want to do for this patient is to control the root cause, which is diabetes. So we have to get him on a regular diet, a good exercise regime, and to control his diabetes by giving proper medications. We would also like to give anti-VEGFs like bevacizumab, ranibizumab, as well as aflibercept. And we just had a discussion regarding all of this, so I wouldn't go into all of the details again. So the other line, if we have given these, we have given monthly injections of anti-VEGF, we have given for 6 months but not responding. So we may shift to regimens like steroids. So in refractory CME, we can give Ozurdex, which is a dexamethasone implant, or we can give triamcinolone injection. So other cases where we have a non-center involving edema, we might like to do the lasers. So the lasers which are available are the focal lasers as well as the grid lasers, right? And the focal lasers are usually used for the microaneurysms for blocking them, whereas the grid laser for diffuse edema can be used. So vitrectomy is usually reserved in cases which have a tractional kind of pathophysiology and in cases of refractory. So let's summarize the entire thing in one slide. So once a patient of DME comes to you, we want to do an OCT, we want to see if it is non-center involving. What would you like to do? We would like to do a laser. If it is center involving and it has traction, what we would like to do? We would like to surgically operate this patient. And if the patient does not have any tractional etiology, we would like to give him anti-VEGFs, or we can move on to corticosteroids in case he has any previous cardiovascular event. So this is the entire thing about DME. Now there are various protocols. We have drcr.net, protocol V, protocol T, protocol I, but I wouldn't go into too much detail. So we'll discuss it in the next class. Thank you.
Good.
Ma'am, if patient cannot afford anti-VEGF, okay, this is a audience no student question. If patient cannot afford anti-VEGF, what should I do?
That also the patient cannot afford. Is there something cheaper than glasses, which you can offer? That is what, sir, that is what this student wants to do. Which steroid?
Sir, I have a question. Do all cases of DME need treatment? Teacher, is it based on your experience or based on some literature? Okay, thank you.
So we have Dr. Naik here. He is going to present to us approach to a case of ptosis.
Yes, sir.
Right. Can we start his time now? Yeah.
Good evening, students. Here comes a patient with a cosmetic eye disease. Do you know what it is? Let's discuss how to approach a case of ptosis. First of all, ptosis is the abnormal drooping of upper eyelid. It can be classified as congenital or acquired. Congenital can be simple and complicated. Acquired can be aponeurotic, involutional, and traumatic. We can differentiate congenital and acquired ptosis by some lid features, like on down gaze. In congenital ptosis, we have a lid lag, while in acquired ptosis, the ptotic eye droops down. We have myogenic ptosis, which have myasthenia gravis, chronic progressive external ophthalmoplegia, and myotonic dystrophies. Neurogenic ptosis may be due to third nerve palsy or Horner syndrome. And we have mechanical ptosis due to lid mass and tumors. Now, how do we proceed? We proceed by taking a good history, a detailed examination, systemic evaluation, and management. While taking history, we look for the time of onset. It differentiate between the congenital and acquired, and we can ask for the old photographs of the patient. We can go for what is the mode of onset. It is sudden or gradual. We can look for symptoms are worsening or improving, like any diurnal variations are present in the symptoms, any history of trauma or surgery is there, or any other ocular systemic involvement. On examination, we look for chin elevation, brow elevation, and facial scars. Facial scar defines there is a trauma, and it is a traumatic ptosis. We can go for lid measurements like palpebral pressure height, lid creases, brow height, marginal crease distance, and amount of ptosis. We can also measure LPS function and MRD1 and MRD2. On examination, we can also look for its unilateral ptosis, that's the bilateral ptosis. This is how we rule Bell's phenomena, and that is the Marcus-Gunn-Joe winking. LPS function, it is the most crucial measurement to decide which type of surgery to be performed on the basis of amount of upper lid excursion, we have graded it into excellent, good, fair and poor. And in children we cannot measure, so we use the ELIF sign. On ocular examination, we look for corneal sensation and strabismus is there, we look for extraocular movements and visual fields. We can rule out myasthenia gravis by eye spec test and phenylephrine test. While grading the ptosis, if it is below 2 mm the normal, it's mild, and if it's more than 4 mm it's severe. Anything in between, it's moderate ptosis. While managing the congenital ptosis, if a child has a high risk of amblyopia, we use tarsofrontal surgeries, and if the child has a low risk of amblyopia, we can observe the child, or on the basis of the levator function, we can do levator resection or sling surgeries. In adult, we use levator resection and sling surgeries. On aponeurotic ptosis, we usually do external levator advancement and frontalis muscle suspension. While myasthenia gravis is mostly managed medically and CPEO is managed with crutch glasses. While surgeries based on the LPS function, if the LPS has an excellent function, we can do fascinella servate or molar muscle resection. While if it is a good or fair, we do levator reconstruction. If it's poor, we do supramaximal levator resection and tarsofrontal sling. While concluding with a detailed history, thorough examination and proper systemic evaluation and choosing the right surgical technique, we can achieve the good cosmetic and functional result. Thank you, student. I hope you have understood everything. We will meet in the next class.
Okay. Sir, I have one complaint. Students were gossiping and you never asked them to stop.
I will try, but...
Okay.
And
didn't he ask you to write the names of the people who are talking in the class?
I'm not the monitor.
I will make you monitor in my next class then.
Okay, I have one question.
Yes.
So what is the difference between simple and complex congenital ptosis?
Ma'am, if it's only the ptosis without any other systemic associations or any other ocular manifestation, it is simple. And if it is associated with any other like low palpable height and any strabismus is there, it is associated with any squint and any other systemic illness or congenital defects, it's complicated.
Okay, yours was approach to ptosis.
Yes, sir.
There was no need to go for surgery, etc. All right, because if you compress lot of information, 4 minutes is not enough. You will move superficial. All right,
yes.
All right, okay. So that's the Maharashtra team.
Thank you.
Now over to the Delhi team. Dr. Balla has come here. First in we have Dr. Abhijit. Abhijit will be presenting on recent advances in retinoblastoma. Yeah.
Look at child in examination under anesthesia. We can miss a subtle sub-millimeter RB. So they used a handheld OCT to look at these, and they came out with 2 new signs. So now please pay attention. In that square dotted box, this is the fishtail sign. It is expansion of inner nuclear layer, and shark fin sign, it is a kink in outer plexiform layer and displacement of outer nuclear layer. So this is same. There are similar case reports using handheld OCT. I would like to talk about this paper. So MRI can predict prognosis of a case. So we need not wait for enucleation, and MRI can even predict what will be the effect post neoadjuvant chemotherapy. So you give neoadjuvant chemotherapy to suppress tumor, but based on MRI findings, they classified into presumed optic nerve involvement, that is only optic nerve enhancement. In those cases, you don't need neoadjuvant chemotherapy. It is already a standard practice. And overt optic nerve involvement based on the length or up to which optic nerve is involved. So accordingly, MRI was able to predict event-free survival, and upfront enucleation can be advised for only optic nerve enhancement, and if there is thickening, then MRI can predict the outcome of neoadjuvant chemotherapy. Secondly, in the similar, as a part of similar study, they even predicted that enhancement pattern. So this is not thickening, now it's only enhancement. In enhancement pattern, they give 3 different patterns: solid, tram track and punctate. Okay, please pay attention. So solid enhancement pattern appear to correlate better with the histopathology of optic nerve involvement after the enucleation. So even enhancement pattern on MRI can predict tumor invasion in the optic nerve. And lastly, I'd like to discuss precision intravitreal chemotherapy, where the intravitreal agent is directly injected close to the seeds, and the eye is not jiggled afterward, and the child is kept in a position, and it has shown to lead to less toxicity and reduction in number of injections. Thank you.
Good. These students have something to ask you.
Any questions?
Yeah, it's okay. So retinoblastoma is a cancer of the eye, sir?
Yes, sir.
Okay. So it went above my head, sir.
I thought when the students are coming, they would have read at least something.
Yeah, but I am not from RP Center, sir. Sorry. I'm an ordinary student.
Next.
No, we are students now. Sitting in Andhra Pradesh.
Next presenter.
Thank you, everyone.
Dr. Lavanya will speak to us about approach to a case of corneal ulcer.
Good evening. अरे good evening तो बोलो. Job.
Good evening, ma'am.
ठीक है, चलो. Good evening. Today I am going to present our approach to a case of corneal ulcer. Coming to corneal ulcer, the basic definition is discontinuation of the normal epithelium associated with edema and the cellular infiltration. The main objectives are differentiate it from infective versus non-infective, find out the causative organism, and start the treatment and look for signs of healing. The symptoms which the patient presents are generally pain, redness, discharge, foreign body sensation, photophobia, and diminution of vision. And when the patient complains of pain, generally the superficial ulcers are more painful, and there will be sudden relief of pain, then it is generally perforation. And viral ulcers are generally associated with watery discharge, bacterial with mucopurulent, and pseudomonas with greenish yellow discharge. And coming to the risk factors, keep a close look on the risk factors, ocular risk factors like trauma, contact lens, lid and adnexal pathology, systemic like diabetes, and occupational like farmers and animal handlers. Coming to evaluation, first when you see the patient, see for the external examination, general appearance, eyelids and the lid closure. Visual acuity should be checked and intraocular pressure should be measured. And slit lamp examination, check for the tear film, eyelid, conjunctiva, scleral involvement and AC reaction. And documentation of the ulcer with serial clinical pictures and color diagrams is very important. Coming to ulcer examination, check for the location, size, shape, margin, because that will help you in the diagnosis and for the treatment. And the epithelial defect should be measured in the longest diameters and surrounding area to look for the satellite lesions. Infiltrates should be measured separately from the epithelial defect. Corneal sensation should be checked and corneal thinning and perforation should be noted. There will be mainly 3 differential diagnoses. Either it could be bacterial, fungal or viral. And these are the risk factors and the symptoms which are put into a table which is already discussed. And coming to signs, bacterial keratitis generally have AC reaction and associated lid swelling and chemosis. Fungal has a specific look of dry looking ulcer with feathery margins. And viral has dendritic ulcer with linear branching. Acanthamoeba generally has a ring infiltrates with the epithelial defect and stromal thinning. Investigations and management, I am not discussing now because it will be over your head. And investigations, mainly the samples are conjunctival swab, corneal scrapings, which can be sent for KOH staining, culture, ASOCT and corneal biopsy can be done. And these are the investigations for PUK. And the basic outline of management, staining and culture reports should be seen, gram positive, then go for cefazolin and tobramycin empirical therapy, which could be modified after the culture sensitivity report. And KOH positive, start the antifungals like natamycin 5% and amphotericin B. And others are start the treatment according to the organism. Also, the patient can present with perforation. It is the management is based on the size of the ulcer. Perforation. Less than 3 mm, 3 to 5 mm, and more than 5 mm. Thank you.
You have 1 minute to spare.
I want to ask question to.
Ah, very good. Excellent. Okay.
I want to ask question to the first bench middle person because he was not paying attention to the class.
Paying attention. फिर भी आंसर कर देगा.
Yes, ma'am.
No, not Sardarji sir.
I'm the mentor.
Ma'am, he was diverting my attention.
Tell which is good between corneal biopsy and corneal scraping. This is already discussed in the previous class, so I think.
Ma'am,
you would.
I think corneal scraping is better because I can do that. Biopsy तो मुझे पता नहीं, मैंने किया ही नहीं.
But that is a wrong answer. Biopsy will yield you better results in non-healing keratitis, no?
मैम आपने ठीक से बताया नहीं था last class.
Yeah, not attentive in the previous class also.
बहुत जल्दी बहुत ज़्यादा बोल दिया.
I have.
This something I didn't understand. You put it as gram staining, then KOH.
After doing the scraping, we will be sending it for 3.
Which should be done first?
Gram staining will be done first. First, you should rule out the fungal cause, and generally we'll start with the empirical treatment. Then, if the fungal report comes, we'll start the antifungals.
I'm sitting in my clinic. I can't do if I go outside of this class and I start my clinic, I will not have gram stain.
Should I
But I
explain you
can
the
buy a 10,000
basics
rupees
of gram
microscope
staining?
and sit. I can buy a 10,000 rupees microscope, but I can't do a gram stain.
You can go with the signs and symptoms and see whether it is bacterial or fungal, like mostly.
Yes, I want to know that. One. And
Mil-
second thing is, she will take in the next class gram stain and
Yeah, gram stain and KOH.
I have 2 simple questions from the lecture only.
And you know who ma'am is? Ma'am is the topper of the class. She is asking question in all the lectures.
What is the, because I am an uninitiated person, I am not an ophthalmologist, so I can ask questions like a student. Thank you for your compliment. What is a superficial ulcer and why they are painful? And what is a satellite lesion? I didn't understand that.
Superficial lesions are which involve the epithelial layers and the subepithelial layers. They will be more painful because of the nerve plexus which are present, subepithelial nerve plexus. And satellite lesions generally they are seen in fungal corneal ulcer. That will help you to diagnose the fungal corneal ulcer. They are there is a primary lesion and there are some focus of infection in the periphery to that.
Okay, so we know, very good. So we know now why India is so good in sending rockets, no? At escape velocity. All right, now over to Team Tamil Nadu. Who is the first presenter? Anirudh. So you will be presenting on?
Pointer.
No,
Everything,
what
give her
will
the
you be
pointer.
presenting on?
I'll be presenting on approach to ocular trauma.
Okay, she'll be presenting and teaching us an approach to ocular trauma. All right.
Good evening, one and all. I'll be presenting an approach to a case of mechanical ocular trauma. It's not working.
Then please start the timer again,
Thank you. So first things first, we should know the burden of the disease before tackling it. So estimated 55 million people experience ocular trauma each year worldwide according to WHO, and the most common age group is between 16 to 45 years with male predominance, and it carries a medical legal aspect since it is a grievous injury. So our approach should be taking a good history with proper documentation and detailed examination. In history, we should assess the consciousness level of the patient. We should assess the details of injury, mechanism, duration, the velocity of impact of projectile, point of impact,
if the patient was wearing any protective eyewear during the trauma, if any visual deterioration is there post-trauma, past history of ocular surgery and medical history, if any TT immunization was given, and need for MLC. Coming on to examination, we have to assess the visual acuity of the patient using standard Snellen's chart. In lids in orbit, we'll assess the integrity of lid margins, swelling, ecchymosis, laceration. We have to evert the lids, very important, to rule out foreign bodies. We have to palpate the orbits for bony tenderness or any step deformity. Enophthalmos is seen in case of blowout fracture, whereas proptosis is seen in case of retrobulbar hemorrhage. Coming on to anterior segment, we should evaluate grossly and with a slit lamp the sclera conjunctiva and cornea. We need to detect any foreign bodies, any laceration or hemorrhage. We can even stain with fluorescent to evaluate abrasions and also for Siegel's test. The anterior chamber can be looked for hyphema or reaction, and in case of ALC breach, there can be development of cataract. Pupils are very important. We have to assess the size, shape, the pupillary responses, both direct and consensual, the relative afferent pupillary defect, which depicts that there is optic nerve damage, and also if patient is complaining of diplopia and upward gaze, it could be orbital floor fracture with inferior rectus muscle entrapment. In posterior segment, we need to rule out lens dislocation, vitreous hemorrhage, and retinal detachment with indirect ophthalmoscopy. We should use non-contact method or even general digital tension assessment of IOP, and very important point is we should never check intraocular pressure in case of confirmed globe rupture. Coming on to terminology, Birmingham Eye Trauma Terminology System. It says that it's divided into closed globe and open globe. If the injury is by a blunt object, it leads to contusion. If it's by a sharp object, it leads to lamellar laceration. Similarly in open globe, if it's by a blunt object, it leads to rupture, and sharp object will lead to laceration, which is further divided into penetrating, perforating, and intraocular foreign body. Coming on to 7 rings of Campbell in blunt trauma, which are very important. First of all, iris sphincter tear. Secondly, iridodialysis. Then comes the angle recession, cyclodialysis cleft, trabecular meshwork tear. Then we will look for zonal dialysis and retinal dialysis. Investigations, we can go ahead with AP and lateral view of X-ray. We can do B-scan if fundus is not seen on indirect ophthalmoscopy, and CT scan to rule out foreign bodies. Also, we can go ahead with ASOCT to diagnose cyclodialysis cleft. Coming on to management, in case of lid laceration, we have to do primary suturing. In case of subconjunctival hemorrhage, we can just observe. In case of corneal aberration, we can do patching or we can put BCL. In case of corneal foreign body, we have to remove it. In case of conjunctival laceration, if it's small, we can observe. If it's large, we have to repair. Similarly, in corneoscleral laceration, we have to do prompt repair. In case of hyphema, if we can go about conservative management unless the IOP increases. And cataract, we have to do careful surgery with IOL implantation. Posterior segment, if lens dislocation is there, we can go ahead with pars plana vitrectomy with phaco-fragmentation. In case of vitreous hemorrhage or RRD, we can go ahead with pars plana vitrectomy with or without tamponade. And intraocular foreign body needs prompt removal if reactive. Thank you.
Any doubts?
Mention of tetanus in the history taking. What was it about?
Ma'am, if any any ocular trauma comes, we'll assess if they have already been immunized with tetanus within 5 years, because it can be metallic object which has actually hit the.
All right.
Thank you.
All right.
That was a beautiful slide.
Thanks.
Okay. Now Kavya Priya will be talking to us about approach to a case of advances in amblyopia. I'm sorry. Advances in amblyopia. Kavya Priya from Tamil Nadu, Team Tamil Nadu. No, the next one is Kavya Priya. First one is Anirudh Kaur. And immediately after this, our esteemed other host has provided us with a lot of gifts. He will be talking to us again about that after Kavya Priya. By the time they will compute and give the results right away. No more transparency than this, right?
Start.
A very good evening to one and all. My talk will be on recent advances in amblyopia. Actually, a little disclaimer. I'll be going really fast, so if you want to understand, I have to just pay attention to what I talk and not look at the slides. So why this topic in the first place? Why newer advances when we have this conventional treatment of patching, penalization, etc.? Because not all patients receive this treatment with a smile like this one in the picture. So there is poor compliance, there is intolerance to atropine eye drops, patches, and how do we deal with the amblyopia that occurs in adults? So in addition to that, there is also failure rates and also recurrence, and also there is poor binocular outcome. So it all starts here, the retinogeniculocortical pathway. So you don't have to think too much about it. You just have to remember there is something called ocular dominance column that is present in the V5 of the cerebral cortex, and which is susceptible to ocular inset at a period called critical period, which ranges from birth to 7 years of age. And the good thing is that plasticity can be modulated by these therapies, which I am going to discuss. So vision therapy, binocular therapy, orthoptic treatment, liquid crystal display glasses, drugs, and physical therapy. So we'll just see one by one in detail. So vision therapy has two components, orthoptics and perceptual learning. So what this basically is, in orthoptic they will get anti-suppression charts, and then patient is asked to find out how they feel, which letters are blocked and through which eye, so that patients will realize that they have suppression and then use both eyes together. And coming to the next is the perceptual learning. Perceptual learning is based on the old adage, practice makes perfect, which means the patient is given a repeated, patient is asked to do a simple task repeatedly over a period of time, and then they get trained in that, and then that will result in reduction in the lateral inhibition. Okay, well, what I put in the picture is a Gabber image, which has a form and shape that represents an exact image of the receptive field in the brain. So working with these images will stimulate that particular area in the brain. So we all know the definition of amblyopia, but we think it's a problem with the one eye. But we all forget that the other eye is also involved, which leads to a bilateral decrease in contrast sensitivity, spatial localization, etc. So we need to find a therapy that will target this abnormal binocular interaction and also improve the binocularity. So for which we have something called the dichoptic training, which will give two stimuli independently to each eye, and the patient is asked to integrate the two images to perform the task. So we all heard of the term Binocs, which is a well-known dichoptic training digital platform, which the patient is asked to perform 2 to 3 sections for at least 3 to 5 weeks. Okay, this dichoptic therapy can also be incorporated into mobile games and also video games, and this is interesting because it is more entertaining and involves more patient participation, as it's rewarding. Studies say it can lead to boredom, but I find it more addicting than. Okay. So coming to orthoptic treatment, it is a novel treatment. It is interesting because it was developed by an Indian ophthalmologist, Dr. Santhan Gopal, which this system directly stimulates the M cell in the magnocellular pathway and thereby improves the stereopsis and visual acuity. It's just like a C fields. The patient is asked to look at the central point and then see how many points are projected peripherally and then give a count. And we also have smart glasses, which has a liquid crystal display, and this display will alternate between opaqueness and transparency, just like patching, but it has better compliance than patching. Okay. We have heard about the drug levodopa used to be used for amblyopia therapy. The studies have found donepezil, citalopram, ketamine are also found to have an effect on improvement of binocularity in amblyopia. But the principle is they target at the neurotransmitter level, which will delay the neuroplasticity. So if you have not paid attention to any of the things, I ask you to just listen to the slide. So this therapy is not gold standard, and gold standard is definitely the occlusion therapy, and this are task dependent and should always be combined with optical correction and patching. And these are laboratory tests, and there are no home-based training, and there is no long-term comparison.
Okay, so over to the students, and one student has come very late. No, madam has come. This is the last presentation of the Teachers of Tomorrow. We have 5 teams. Wonderful. Let's give them a big hand first of all. Okay, 5 teams and 5 great mentors. They've all come, they've all sat, they've all been with the teams. Ma'am, while they're computing, you have to ask some questions, no, first.
Actually, there are tests for monocular testing and binocular testing. Monocular testing mostly, just like patching, it helps to stimulate only one eye. When binocular, stimulate even to both eyes, and then more higher contrast. If you wear those glasses, you'll be able to differentiate the contrast images between the two. So you must try it once.
He has 624. What do you call that? With best corrected.
There is anisometropia.
Anisometropia?
With amblyopia.
Both eyes amblyopia or one eye amblyopia? I didn't understand. Because your definition said 6 by 12, 20 by 40 or worse.
Amblyopia can
This
be
guy is 20 by 30.
Can be bilateral also. So more unilateral than bilateral. So patient can have amblyopia in both eyes also. That's called anisometropic amblyopia.
All right.
Thank you.
So now you can compute the marks, and by the time you can.
So the awards I have already announced before. So there will be a trophy for the winner team, and gold medal will be given to the 3 mentor and mentee. First and second runner, they will receive silver medals. And case prize, I don't know, when Dr. Namta will be speaking, you can request ma'am. She is the in charge. cash rewards. So now I would like to invite all the mentors. Yeah. So the direct transfer. Digital India. So now I would like to request all the mentors to come onto the dais and say something about their team and about the performance of others. Stage. This is your test.
First of all, I would like to congratulate the scientific committee, Namrata Sharma madam, and Dr. Gopal Pillai and the team of Teachers of Tomorrow for bringing out such wonderful quality for our students. And actually we have gone through the efforts of how they have taken the pains to prepare their talks. Many of them are doing it for the first time, so it really boosts their confidence and morale. And they are also looking at a different perspective as to how their teachers are teaching them. So their attention towards their teachers also and the respect is now increased manifold. So I think it's a very good experience, and it's been a wonderful journey for the last many days where we have been mentoring them, and we have been so involved. It's like our own kids giving a talk like this, and we have enjoyed this no matter what the result, but we have enjoyed going through this, and I feel the students also have enjoyed, and it has given them a very good platform. Thank you all so much.
I think it is a very wonderfully crafted session, and it really combines not only their teaching skills, their confidence level, how they face the audience, and some of the answers were so witty and so nice that it really showed. Like one of the contestants asked, you were not paying attention. Or second one said, you are a very bright student, you will become a very good teacher once you grow up. I think that's what, so very good answers. So it is not only your academic skill, your academic knowledge, how you face the students, how you let your students imbibe the knowledge which you have. And one thing is that eye contact, how you face the students. It's not that what you are doing, you are just looking at your computer screen, there is no involvement of the students. You engage your students, you get them involved, you create that interest. So even a boring topic can be made very interesting. And I think wonderfully done. We have a very nice talent from all across the country. And I think all of you are winners, irrespective of who is crowned winner today. And Dr. Namrata madam will definitely give cash prizes to everyone. I think so.
I really appreciate all the students, I mean all the mentees who have represented today. They have shown the excellent confidence and their energy levels, and I'm damn sure that we'll have teachers of tomorrow will be better teachers than the previous teachers or the today's teachers of this era. I wish all of you the very best. Thank you.
Odisha, please.
all the participants were really, really good. I know the amount of hard work each one of you have done behind presenting your presentation here, the hard work you have done all the days, not only the mentees but the mentors also. We all are thoroughly involved in this. And the presentation speaks about the confidence which you have, isn't it? A good teacher is incomplete without a good student. So it doesn't matter you are a first year PG or a second year PG. It is all about how you deliver, what you know about the case, and how much effective you are in making the person ahead understand the topic. For example, my student is just first year. He was telling me, ma'am, proptosis, I would have delivered it better if I would have been like a second year PG. I said, no, that's not the case. You have already beaten 21 PGs in the Odisha and you are here standing here talking this. It is not about your age, it's not about your the graduation year, all right? It's all about you, the belief in you, okay? The confidence. Everybody was good. Thank you.
Shreyas, you have to say something. Now this is the
AIOS
test
to
of
give this
mentor.
opportunity. What I found when I was mentoring my mentees is that first you have to be thorough with your knowledge to become a good teacher. So first you should be a good student to aspire for the knowledge, then only you can transform the knowledge to your students. So thanks.
Madam, Namrata Madam.
I think this is a great concept, and first time when I saw Teachers of Tomorrow, that was in Kerala State Ophthalmic Society when Dr. Gopal Pillai and Srini had called me, and I that time had thought that we would definitely do this program. I'm happy that this was done from last year and it is doing so well. Anything Gopal does always very well. So 3 cheers to Gopal for this concept. I think it is very difficult to teach. That is what I feel. When we make presentations, it is very easy to make presentations at our level, pull your videos, pull your experience, and then you go and present. But to come to the level of the student who's a first year or second year, you have to entirely modify your lecture. You cannot give the same lecture to them because you have to come down at their level. And always, whether it is, presenting in a conference or presenting in a class, you have to know who your audience is. You may be talking hi-fi things, but it doesn't matter if your audience doesn't, understand. So I always feel that when you have to make lectures for undergraduates, it is the most difficult thing to do because you don't know what to delete. And for postgraduates, again, it is very difficult because we expect they would know everything, but they really wouldn't know everything. So you have to go down to their level and then, deliver. One more thing I wanted to say is sometimes 3,000 pages of a book you may just, go and you may not pick up the important thing that you should know about that particular topic or the problems which only an experienced teacher can tell you for that particular topic. So I think here is the role of the mentor. And of course, it goes without say that when a mentor and mentee, they interact, or when a teacher and student interact, that is a bond for always. I can count at least 10 or 15 of my students here. Ellen is not listening, he's become a judge already. So he was junior resident with us. Then he is, very bright junior resident, now of course a consultant. Now junior resident from RP Center again. And Abhijit is of course the RP Center people. Sai is, they've done very well in their senior residency exams. And I think the greatest one is here, Praful Maharana. So that's what I'm saying. Sometimes you really can't make out. He wrote first paper with me and he said this is a case of microbial keratitis and I want to publish. I said okay. And then without my actually having to say anything, he got the paper and he not only got the case, but he also got the review of literature at that time where there were not many cases. Instantly that article got accepted. And then I just thought that this is a bright spark of light. And when you find such talent, I mean everybody is talented, but when you find such talent as teachers also, please nurture them. Everybody has positives, everybody has negatives, but identify the talent, and as a teacher it is your duty to nurture them and to see that it blooms to the fullest. That is your strength and that is what you are supposed to do and that is what you will be ever remembered for. I'm sure all the teachers here would agree with me what I am saying. So thank you again, Gopal and Praful, for doing this. And the the student with the hottest temper was Ellen Kumaran.
Judges, are we ready with the winners? Okay, please announce. I'd request Dr. Namta ma'am to please come onto the dais.
As per the GBM, the cash prizes are not to be given. But having said that, we will convert it into your travel and registration for the conferences. So it is not that you're not going to get cash prize. You may not be able to party, but then very aptly for this program of Teacher for Teachers, you will be given complimentary registration and so that you gain more knowledge by coming to conference again next time. So that we will organize for you. We'll try to organize travel also for you, but definitely the registrations will be complimentary.
So,
So thank you, Praful, for having me here. Very good evening, Namrata ma'am. Everyone, good evening. And I had a lot of fun and a lot of learning. Actually, all the teams were very good. Everyone did extremely well. Also, we have a small apology to the first team because they did not know what we are going to mark for. So, but it can be borne by them. Because otherwise also, we have corrected. We have given half marks extra to the first team presenters because they did not know the marking system by then. We are having two runner-ups, runner-up 2, runner-up 1 and the winning team. I will just announce the runner-up 2 and then my better partners in judging, they will announce the runner-up 1 and the team, the gold medal winner. So the runner-up 2 is the team of Tamil Nadu, and so we have Kavya. Yeah. This is silver, yes. There are 2 silvers and there's 1 gold. Okay, so you are the mentor.
Shreyas, you should also join them. All the mentors.
First of all, I think Madam has already said, all of you did equally well. It was a learning experience not just for you people, for us also. And it was very important for me because after 21 years, I attended a class, slept in the class, forgot many things, and still learned a lot. Thank you for all of that. Now, the second runner-up, second has been announced again, sorry. First runner-up is Team Odisha.
Yeah, I think now time for the winner. Yeah, I think, yeah. Praful, I think it's a really good concept, because what I believe is the best way to learn is to teach. So once you start teaching, you have to learn everything. I think in that way you have really inspired all these people to come forward, and a great concept, and I really congratulate you for that. And all the teams, as you told, the margin is very less. It's only 0.5 or 1 marks difference, and all of them have performed so well. And the winner team is from, any guesses? Yes, Maharashtra. Congratulations, madam, for doing wonderfully, mentoring them. Neelambika and Monish Nayak, please come out to the dais. The madam will announce that.
All the participants, please come onto the stage.
So we have one more prize, yeah. So I want to announce the name of the best teacher and the best runner-up teacher. So the runner-up in the best teacher category is Rohit Amol Chavan. Dr. Rohit Amol Chavan, you are the runner-up. Congratulations, very well done. And the best teacher is, any guesses for best teacher? Nilambika. Congratulations.
किसका मोबाइल है?